Okay. One of you guys emailed me to ask if I could meet today at 2. Who was it? One of the youngsters emailed me to see if I could meet today at 2 and didn't come to class. So the answer is no. If you didn't come to class, I was going to tell you that I would do it on Monday, but now I'm not going to tell you anything because you're not in class. Okay. So let's see how far we will get. I think we were about to do ovaries, right? Yes? Go ahead.
You said you had a story for us last time we were walking out the door.
Oh, yeah. I totally would have forgotten. Okay, so we'll start with this very subtle picture and just keep that in your mind. I mean, I know it's in half of your minds all the time anyway. Well, not half, like a third. Actually, I have no idea. I wanted to tell you guys this story about it. This is like not a scientific study, but I found it really interesting. When I first started teaching reproductive system at a college level, because I used to teach genetics, which is like none of this story, right? But when I first started teaching reproductive system and anatomy, I realized like how much people don't know about anatomy because nobody really talks about it, and if they do, they use the wrong words. And I saw this study it was just a woman's magazine. It was just like, I think Mademoiselle or not a scientific magazine, not even Scientific American, okay? And definitely not peer-reviewed. But it was interesting nevertheless. So what they did with this little study was they interviewed, I think it was like 50 men, still a small sample size, and they took a photo of them, and then they asked them, what kind of a lover do you think you are? And the answers ranged from, I have no idea what I'm doing, but I enjoy the hell out of it, to I rock her every time, and everything in between. And then, in addition to those two things, they also just gave them a line drawing of the female external genitalia. Just a line drawing, nothing like really salacious, and said, just put an X over the clitoris. That's all you need to do, just put an X over the clitoris. And one of the most shocking things I've seen was the combination of like the guy's statement about what kind of lover he was and like where he thought the clitoris was and his picture. I'm sure he didn't know that his picture was going to be published without like that. Anyway, so over here in the urethra, up the vagina, down near the anus, like only 30% of them actually got it right. And these were grown-ass men, okay? So that is one of the reasons that I think it's absolutely necessary for me to do this, because if we spend our whole lives not talking about it, and then even if you go into your marriage virginal and pure, you have no idea what the hell you're doing because nobody ever talked to you about it. And you're not supposed to watch porn, right? And by the way, it doesn't work like that anyway. I don't know. Don't get your expectations set on that because that's not how it works. And there's not good lighting all the time, so just so you know. Anyway, so that let me know that I had a job to do here, and it's public service. So the clitoris, you found it, and you will find it on a test. And now let's talk about the ovaries. And the ovaries are nowhere near as interesting. Mostly you never really know that you have them until you try to use them. So the ovaries, any of you guys take lab on Redwood campus? No? Okay, so the Redwood campus, that's the only lab that we have a female with ovaries and a uterus, because almost all of our cadavers are above age 60, and in that generation, complete hysterectomies were way more common than they are now. So just took everything out. So the reason I picked her when we went to the body donor program was because it said she possibly has a uterus. I mean, they don't do exploratory when they get cadaver. So I picked her, and she did. And in addition to a uterus, she's got ovaries, and one of them has a huge ovarian tumor on it, like that big. It's amazing. What? Somebody say something? What? Wow. Yeah, it's cool. Have you seen it? We actually lived there, but I don't remember seeing it. Oh, go look at it. Yeah, it's like this big. I was confused. I thought there was an extra organ that she grew that I didn't know about. I was like, what is that? I have no idea. And luckily I didn't say it out loud because it was really dumb. But I don't know what a tumor looks like in the ovary. It was like a big sack. Anyway, so the ovaries, when I first saw them on a human, I was actually kind of surprised because they're kind of small and unimpressive. They're like, that big, and they have the texture of like large curd cottage cheese. It's just like, oh, that always makes an impact. But it is what they look like. They're kind of lumpy on the outside, and they're not very big. And so they have a couple of functions. Of course, they have to produce gametes. And gametes are, right, your sex cells that have how many chromosomes? 23, yes, 23 chromosomes. The only healthy chromosome number for a human is 46. If you want both parents to contribute, you better only give 23, right? Okay, so they produce gametes and they also produce estrogen and progesterone. Tidbit about estrogen, we already talked about progesterone. Progesterone is the ovaries telling the uterus what to expect, right? And estrogen is a bunch of things. It's relatively complicated, but it is responsible for what we call the secondary sex characteristics in a female. The primary sex characteristics are putting everything in the right place, which happens between 6 and 9 weeks post-implantation. So that's just putting everything in the right place. And then the estrogen at puberty will expose that negative, will like make it fully develop. So the ovaries will become functional, right, at that point. Pubic hair, changes in body fat development, breast tissue development, and fertility are secondary sex characteristics. That make sense? Okay. So that's a little bit about estrogen. It does tons of other things too, but the ovaries are, of course, homologous to what structures in males? Yes, exactly. And here is another design flaw, if you ask me. The ovaries, I was super surprised when I learned this, don't actually contact the fallopian tubes. So here's your ovary, and here's your fallopian tube. What happens is they are not hooked together, which means that when a woman ovulates, she actually ovulates into her peritoneal cavity, and you just hope that it makes it into the fallopian tubes. Does that make sense? They're actually not stuck to each other, and I don't know about that. I disapprove. So it's not stuck. Now, with high levels of progesterone, what will happen is those fimbriae will fold down over it, and they're holding on to it, but it's not like a seal, right? So you just ovulate into your peritoneal cavity, and then what happens is we have what's called the courting of the oocyte, and the courting of the oocyte is how you convince the egg to go into the fallopian tubes. And it's a couple different things. Remember, those fimbriae will fold over it, okay? And then remember that the fallopian tubes are lined with ciliated cells. Remember that? Ciliated simple columnar epithelium, right? So those start waving in, right? And then the smooth muscle in the wall also will start contracting so that you get sort of the suction effect that hopefully will bring the egg into the fallopian tubes. Does it always make it in there? Nope. And proof of that is that you can have what are called ectopic pregnancies. And an ectopic pregnancy is a pregnancy that occurs anywhere but the uterus, the inside of the uterus. So you can have a fertilization and an implantation happen in the peritoneal cavity. Because this thing isn't closed, the sperm swim out of there too, which I did not approve of. Okay? I only approved of it in my reproductive tract. That's it. Okay? But apparently it can swim up the vagina, through the cervix, through the uterus, down the fallopian tubes, and swim into the peritoneal cavity. If the egg is in there and the sperm is in there, fertilization can happen in the peritoneal cavity, and then you can try to implant on something that is not the inside of the uterus, like the urinary bladder, or an intestine, or the mesentery. And those are called ectopic pregnancies, right? And they can't be carried to term. Of course, there's no way for it to get out, but in addition, they're really, really dangerous for the mother and generally can't be carried to term, with one exception. I always hear like anecdotal stories about like, oh, this person had an implant here, but the only thing I'm going to trust is a peer-reviewed scientific article, and I did find one about one ectopic pregnancy being carried to term because it actually implanted on the outside of the uterus, so it had access to the same blood flow as the uterus. And she carried the baby to about 24 weeks, which is in the second trimester, before they decided it was too dangerous for the mom and the baby. And of course they had to deliver by cesarean section because it ain't coming out the vagina, right? They delivered by cesarean section. When I read the article, the mom and the baby were both living, and it was like 4 months afterward. And so the baby apparently had relatively normal development for a 24-week, which is way premature. 40 weeks is gestation. So anyway, but mostly they can't be carried to term. with that little exception. Okay, so blood supply to the ovaries. Ovaries. I'm just making hybrid there. To the ovaries, ovarian arteries, the gonadals in a female, right, are branches directly off of the abdominal aorta. Yes. You also have another branch that comes off of the internal iliacs. The internal iliacs gives rise to the uterine, and then the uterine will actually give rise to another branch that goes to the ovaries. So you got two different sets of arteries going to the ovaries. Nerve supply, they are innervated by the autonomic nervous system, and although I didn't put it, they also have some sensation as well. Your ovaries can hurt. Some women can feel it when they ovulate because the ovulation process is actually kind of violent. It actually, during the ovulation process, you actually bust the thing out the side of the ovary, and some women can feel it when it actually happens on one side or the other. Okay, so let's look at the tissue layers of the ovary. The tissue layers of the ovary, and we'll sort of talk about the function of the ovary as well. So if you look at the ovary, the big picture is that you've got a cortex, right, around the outside, and then a medulla. The medulla is not a whole hell of a lot going on there. It's got blood vessels, nerves, lymphatics coming and going to the medulla. The outside is where the interesting action occurs because that's where meiosis is actually occurring. And meiosis is, of course, a reduction in the chromosome number and chromosome content in preparation for making a gamete. You guys with me on that? That's where meiosis occurs. Okay, so let's do the outer two layers before we do that. The very outermost layer is called the germinal epithelium. That will be important clinically. And it is in contact / continuous with the serous membrane that's on the surface, the visceral serous membrane. And then the next layer in here is connective tissue called the tunica albuginea. The testes have that same connective tissue, only it's thicker in the testes. And then we run into the cortex and the medulla. Okay, so let's talk about what happens in the cortex because it's kind of interesting. So I'm not going to try to make you remember all of meiosis, but hopefully, I know you had this class, right? Everybody tries not to remember meiosis. They do the same thing with cellular respiration. So meiosis 1 will divide the chromosome number in half, right? It separates the two chromosomes. So I have a chromosome number 1 from my dad and a chromosome number 1 from my mom, right? And then I separate them. After I've done crossing over and stuff, I separate them. And then meiosis 2 actually separates the amount of genetic material because I had replicated chromosomes. Okay, so here's the deal. The idea with meiosis is to make sure that you end up with 23 chromosomes in the gamete, right? So that you can fertilize it with 23 chromosomes and get a normal number of chromosomes. So you have probably heard before, and I want to clear this misconception up, that a woman is born with all of the eggs she's ever going to have. It's not quite true. What she's born with is all of the egg-producing structures she's ever going to have, and that's these guys, and they're called the primordial follicles. A follicle is the structure that surrounds the egg-producing structure as it actually goes through meiosis, and it gets bigger as you finish meiosis. So do you see this follicle getting bigger and bigger and bigger, right? But the cell inside is reducing its chromosome complement, and this is supporting the development of this egg, right? And an egg, by the way, is way bigger than just the chromosomes. An egg has all the mitochondria and all the cell stuff in it. So it's supporting the development of this gamete. You guys with me? So the follicle is the thing that supports the developing gamete. A woman is born with all of these primordial follicles she'll ever have. Those are the things that will go through meiosis. Those are 46 chromosomes. You with me so far? Okay. So what's the difference between a male and a female? Because you've probably heard that a woman is born with all the eggs she's ever going to have and a man continues to make sperm, and it's kind of true because in a male, we will see in the testes that a male not only has these, he goes through mitosis with his primordial follicles and makes more of those, and then takes a bunch all the time and goes through meiosis and makes sperm. So he's constantly making fresh sperm-producing structures. You with me? But you will have all of the egg-producing structures as a woman that you are ever going to have from birth, and they age with you. Does that make sense? As they age, the likelihood of going through meiosis and getting it just right decreases. So when meiosis doesn't happen properly, you get an abnormal chromosome number. You get 45 chromosomes like Turner syndrome or 47 chromosomes like trisomy 21 Down syndrome, right? Does that make sense? So we've got stats against us when we're women. Not only are those aging with us, but how many eggs do you make per month? Generally one. That's the one that will get fertilized. If a male, in addition, his stats are with him, because in addition to making fresh ones all the time, if you make around 150 million sperm per ejaculate, do you think the one with the bum leg is going to win the race? No. So do you see why, as a woman ages, it's far more likely for her to be the cause of chromosome abnormalities? She only makes one, and it ages with her. He makes 150 million per ejaculate, and he's making fresh sperm-producing structures all the time. Now, do males ever cause chromosome abnormalities? Yes, but the stats are not with that. The stats are not against them. And so what the stats look like with the likelihood of chromosome abnormalities in a pregnancy are if you had a baby when you were 16, the likelihood of chromosome abnormalities, I think the last time I looked it up, was something like 1 in 25,000. It's not very high. And most of those, by the way, would be miscarried in the first trimester because your body would say, something weird's going on there, and they just miscarry. Okay? But by the time you're 45, the likelihood of having a chromosome abnormality is 1 in 46. And that is really, really high, right? Does that make sense? Okay, so the follicles, the primordial follicles, you begin with about 1.5 to 2 million of those, but you're never going to have 2 million babies, right? Not even in Utah. And you ovulate around 400 of them in a normal woman's lifespan, from puberty to menopause. Around 400 are ovulated. What happens to the rest of them? Reabsorbs them, uses the parts, recycles them. So the rest degenerate. That's called follicular atresia. So what's going to happen is you go through this process, and as you go through this process, does it make sense to you that as you start to do the maturation and the meiosis process, your estrogen level, your progesterone level will rise, right? And you're telling the uterus to get ready, right? And then the progesterone level is pretty high right when you ovulate to keep the lining prepared. Okay, and then when you ovulate, this structure, this follicle that used to be surrounding the developing egg, stays around as something we call the corpus luteum. And this thing continues to secrete progesterone for that period of time in which an implantation could occur, right? And as soon as you know that you're past the window in which an implantation could occur, this degenerates, and then you start the whole thing over again. Generally one primordial follicle per month is what most women do. There is a predisposition to hyperovulation in some women, and they'll hyperovulate multiple eggs per month, right? Like fraternal twins kind of does run in families. It also, interestingly, evolution is a tricky little bastard because as you get older, not only are you more likely to have chromosome abnormalities, but as you get older, you're also more likely to hyperovulate because it's like, hey, I've only got like 6 cycles left. Let's put 3 in this cycle. So when are you more likely to get triplets? When you're freaking 42. What the hell? That is totally rude. You're like too tired for one, and then you get pregnant with triplets. Okay, so anyway, I'm not going to ask you the detail that I gave you except the stuff in your notes, okay? The other stuff was just FYI because a lot of people misunderstand that kind of stuff. Okay, so you just have to know the detail in your notes. Okay, so we already talked about the medulla. Oh, that's not the medulla. That was the wrong link. Okay, the ovarian medulla is the middle, and the hilus is just the region where all of the tubes come and go from, right? Just like with the kidney, hilus or hilum, that's where it is. Okay, so the supports for the ovaries, the ligaments. People have trouble with the ligaments. You won't have as much trouble with the ligaments if instead of looking at them on a picture or a model and trying to figure out which one's which, you memorize what they're supposed to hook to what. And then it will make it easier to find them. So the broad ligament is easy because it's broad and it covers both the ovaries and the uterus. So this is the broad ligament. It's sort of behind the ovaries and also holds on to the uterus. But then the other two, the suspensory ligament suspends the ovaries from the body wall. So it goes up, right? Does that make sense? And the ovarian ligament goes ovaries to uterus, okay? And if you just know that, you can find them without even memorizing them, right? Okay, so the suspensory ligament is this guy right here, and the ovarian artery and the ovarian vein run through it. I don't know why they didn't continue the picture because it actually goes back behind there and attaches. So that's the suspensory ligament, okay? And then the ovarian ligament attaches the ovaries to the uterus. It's not a tube, though. It's just a ligament. So between holding them back there, holding them this way, and holding it behind them, even though they're not directly attached to the tubes, they're held in place. Okay? So those are the supports for the ovaries. Clinical note. Ovarian cancer. Ovarian cancer has a pretty strong genetic component, at least in some circumstances. So it's worth you knowing if you have a family history of breast or ovarian cancer, because the two of them tend to cluster together. So you need to know if somebody in your family had breast cancer, you need to know it, and your medical professionals need to know it, okay? Or if somebody had ovarian cancer. And the reason is that although this cancer is relatively slow growing, it gets misdiagnosed a lot because the site at which the cancer occurs is in the epithelial tissue, and that's not too surprising, right? The germinal epithelium on the outside. The germinal epithelial tissue always has a higher rate of cancer than other tissues. That epithelial tissue is directly continuous with, in contact with your peritoneum. Does that make sense? Yes, it's directly in contact with the peritoneum. And so if you have those cells starting to behave weird, they can irritate the peritoneum. But it doesn't just irritate it on your ovaries, it's a continuous peritoneum. So you start to have this like, oh, I have abdominal complaints. My stomach hurts, right? But for long periods of time. And of course, when your stomach hurts, you don't go do exploratory surgery because you got a stomach ache, right? You do a whole bunch of other things first. You're like, why do I have a stomach ache? Maybe I'm eating something bad, right? Maybe I'm too stressed. Maybe I'm too this. Like, so it gets misdiagnosed for a long time. And then usually by the time they find it, it's because they did an MRI or did an exploratory surgery. It's later stage cancer. So even though it's not really fast growing, it is the fourth leading cause of cancer-related deaths in women because it's hard to diagnose early. And that's why you should know if you have a family history of breast or ovarian cancer, because your medical professional should know if you have this chronic recurring abdominal complaints, that maybe I'm the person that they should look a little more closely at, right? Why it happens. So higher mortality rate, and most of those cancers are of the germinal epithelium. Okay, so uterine tubes, also called fallopian tubes or oviducts, and those have a couple of different functions. So your fallopian tubes or oviducts, they, of course, are the site through which you would ovulate. If all works well, you would ovulate into there, okay? But if fertilization occurs, fertilization also occurs out here. And most people do not know that. Fertilization does not occur in the uterus. Implantation occurs in the uterus. And, of course, you know what I mean by the difference between fertilization and implantation. So fertilization occurs out here, usually in the ampulla. It's the most likely site for fertilization. And then as soon as fertilization occurs, you will start going through mitosis. 1 to 2, 2 to 4, 4 to 8, 8 to 16, 16 to 32, right? So it's going through mitosis and increasing in size as it goes through here, right? That makes sense? So does it make sense to you that one of the major causes of infertility in women is scarring of the fallopian tubes? Eggs are big to begin with. They are almost big enough to be visible with the naked eye. Under a microscope slide, they're freaking enormous compared to other human cells. So as they start to go through cell division, they get bigger, right? And so that big thing is going to be relatively large, trying to get through the most narrow portion. If you scar the fallopian tube, can you imagine that although fertilization might still happen because sperm are tiny, implantation cannot happen? Does that make sense to you? Okay, and it increases your likelihood of infertility in a woman, and also increases your likelihood of a specific type of ectopic pregnancy called a tubal pregnancy. Does that make sense? If you can't implant in the uterus, you will try to implant in the tube. Does that make sense? Okay, so The uterine tube is a normal site for fertilization. And as far as the layers of the uterine tube, it's not hard. The inner layer we already know is the mucosal layer, and it is lined with ciliated simple columnar epithelium that we learned way back. Okay, and then you've got smooth muscle in the wall, right? And then the outer layer is just the outermost layer is really just the serous membrane that's covering the entire the peritoneum. Really, that makes sense. Okay, so now it's kind of got a strange little shape. The uterine tube goes from this region out here. The cup that will fold over the ovary with high levels of progesterone is called the infundibulum. And the fingers on the infundibulum are called the fimbriae, which actually means fingers. And so with high levels of progesterone, they will sort of fold down. They don't create a seal, but they do increase the likelihood that you will ovulate into the right place. So you got your infundibulum. Then this curvy portion right here called the ampulla is the most likely site of fertilization. And then you got the long portion called the isthmus right here. And then you've got this narrow portion called the interstitial segment. Is that good? And so we already talked about the courting of the oocyte, and that's just all the things that happen that try to get the oocyte in here so that it will actually implant in the right place. Everybody good with that? So you got your fallopian tubes. Okay, so let's talk about pelvic inflammatory disease is one of the major causes of fallopian tube scarring. And pelvic inflammatory disease is really just a general term. So if you have any kind of infection that makes it into your reproductive system, it will go potentially vagina, cervix, uterus can go up to your fallopian tubes. If your fallopian tubes get irritated by whatever pathogen or immune system response that you have, then you can have fibrosis or scarring of the tubes, and that's one of the major causes of infertility. Now, some pelvic inflammatory diseases, because of sexually transmitted diseases, chlamydia and gonorrhea are incredibly likely to cause pelvic inflammatory disease. Ooh, did you guys see that? There was a newspaper article like 2 weeks ago. Did you see this? That looked at the rates of gonorrhea in Utah. It was crazy. I'm so glad I'm married. Oh my gosh. Because people, oh my God, the rates were, I can't remember the number. I want to say like 70% of people that were tested positive for gonorrhea. And oh my goodness, that is awful for so many reasons. It's just gross. Okay, so make sure that you cover stuff up. That's all I'm saying, right? We can pretend that nobody's going to have sex, but I'm not a fool. So cover it up, okay? Gonorrhea. So anyway, gonorrhea and chlamydia are the ones that are really likely to cause it. But also, it can be a non-STD. So it doesn't have to be an STD that causes pelvic inflammatory disease. And usually it's asymptomatic in women. Women have no idea that they got pelvic inflammatory disease until they try to get pregnant. And then they figure out, oh, you have scarring of your fallopian tubes. And it could have moved from your urinary tract into your vagina, or it could be, bad wiping, digestive tract into your vagina, or it could be an STD. Of course, the more sexually active you are with the more partners and the less protection you use, the more likely you are to get pregnant and disease. It's just true, okay? You want to never get pregnant and not have any diseases, well, you just don't ever have sex, and that'll work really well. Okay, so we already talked about ectopic or tubal pregnancies. Before we leave PID, if a woman has scarring in one fallopian tube, it immediately reduces her lack of pregnancy to 50%, right? Because you got one ovary ovulates per month, and it doesn't go right, left, right, left. It goes like some random pattern that you just cannot figure out. But it reduces your likelihood of fertility by 50%. If you've got both of them scarred, you're probably not going to get pregnant by normal mechanisms. But if you're rich, you can do in vitro fertilization because your eggs are probably still fine. But that's $20,000 a pop and has about I think 20 to 25% success rate now. Okay. Let's talk about the uterus. The uterus is the site of embryo development, fetus development. It's also sometimes called the womb. And it is, make sure that you can find it. You would think that women would have some idea about their anatomy, but really there is no reason for you to really ever know what that thing looks like if you haven't ever taken anatomy. It's not like we have any idea what's going on inside there by some magical mechanism. So here is the uterus. Here is what? Urinary bladder. So it's anterior to the rectum. It usually sits both posterior and kind of superior. It usually flops onto the urinary bladder if a woman has not been pregnant until she's sexually excited, and then it pops up. But so notice how thick-walled it is. Even compared to the urinary bladder, which has a decent sized wall. It's got really thick musculature in the wall because it has to pop a freaking baby out of there, right? It's really got to push during that time. So it is in a woman who has not been pregnant, usually about the size of a pear, and has a pretty small lumen. After you have been pregnant, it never goes back to its original size, and neither does anything else. So just so you know, okay? None goes back to its original size. Hollow, thick-walled, got that. So the parts of the uterus, if we start from the top, this is called the fundus, which is really the widest part of the uterus, and this is the body, and that's where, of course, most of the implantations will occur because that's where most of the real estate is, right? And then this region down here, where it narrows, is called the isthmus, and then this region that most people do not know what it is called the cervix. The cervix is the region where the uterus actually sort of extends into the vagina, right? Sort of pokes into the vagina. That's called the cervix. The idea with the cervix is that it should be nice and tight so that if you get pregnant, it'll hold the baby up there while it's still baking. It's going to take 40 weeks to bake that thing, right? And you want it to stay up there. This, by the way, is the thing that they are trying to look at dilating. If they're waiting to see whether you're ready to deliver, they wait for this thing to dilate to the ridiculously small 10 centimeters. 10 centimeters is not impressive enough to get a freaking watermelon out of there, but then they're going to have you start pushing, right? And hopefully after your first baby, it will go right back to almost its original tightness so that you can keep the second one in there, right? So that's what the cervix is. Cervical integrity should be maintained. So if you get an IUD, an intrauterine device for birth control, they have to stuff a little thing up there, and that is not a comfortable prospect because generally this is an out hole. It does not feel very good when something goes up there. In addition, if you start when you start going to a gynecologist, they will start scraping your cervix on about a yearly basis to make sure that you do not have abnormal looking cells to lead to cervical cancer. So this is kind of an interesting thing. So cervical cancer used to be a pretty big killer of young women. It is not a fast-growing cancer, but if you don't catch it in the early stages when it metastasizes, it's hard to get a hold of. But the cervix is lined with epithelial tissue. Okay, not surprising, it's lined with epithelial tissue. And the epithelial tissue has a certain characteristic histology. And sometimes it starts to divide abnormally. And so it doesn't have a really small risk for cancer, but it doesn't have a really fast-growing risk for cancer. So now, if you want any kind of prescription birth control, then when you go in to get prescription birth control, they require you to have a pap smear. And a pap smear is just some little way of rooking women into not dying of cancer. So what they do is they take a little brush, like think about like one of those, it feels like a metal grill brush, you know, those like pokey ones, and they stick it up there, right? And they scrape your cervix right through here, and then they put it on a slide and they send it off to a pathology lab, and then the pathology lab looks at it to see if the cells are normal looking, abnormal looking, or potentially cancerous. And then they send you a card back, usually, that says you have a normal pap smear, you have an abnormal pap smear, whatever. But the good thing about cervical cancer is it grows really slowly. If you can catch it in the early stages, then almost never will the woman actually get cancer and die of it. So you just have to watch it really carefully. So that's down here, by the way. Cervical cancer. It's the third most common gynecological malignancy and the eighth leading cause of cancer-related deaths. It is sometimes associated with an STD, but not always. Annual pap smears increase the likelihood of early detection. Upwards of 50% of women who get cervical cancer get it because they've never had a pap smear. So all you have to do is get a pap smear because you won't generally get to the cancer stage if you get a pap smear. So this is how histology is important to you. I know everybody freaking hates histology, but if you didn't know what the histology was supposed to look like, then you could never know the difference between normal looking cervical cells, epithelial cells, abnormal looking ones in which the nuclei start to look kind of strange, or these that look like they're going through a big mitosis party. Do you see that? You can see all kinds of cells that look like they're in cell division. So all they do with the pap smear, it was named for the guy um, who founded it. His name is Papa Nicolau. And they look at the cells to tell whether they're normal or abnormal. And then the good thing is, like, you don't even have to get freaked out by an abnormal pap smear. All they do is watch it. Because if you have a series of abnormal pap smears, then they can go in and they can, like, burn off the abnormal cells. And then you just have a pap smear every 6 months. And usually most women never get cervical cancer as long as they've been having pap smears. So anyway, it really doesn't have anything to do with birth control. They just figured out that when they started requiring women to have pap smears to get prescription birth control, it reduced the likelihood of young women dying from cervical cancer by 70%. So it's good. Oh, let me tell you the relationship between that and HPV. So HPV is human papillomavirus. And HPV, over time, will make your cervical cells divide abnormally and can lead to cancer. Does that make sense? Okay. So instead of testing for HPV, what they do is just look to see if the cells are dividing abnormally. Does every woman who has cervical cancer have HPV or have had it? Nope. But it increases your statistical likelihood. So now, of course, and not when I was a kid, they have a vaccine for HPV, for human papillomavirus. And the vaccine you can get long before you're sexually active. I think they can get it at 7 or 8 now. Yeah? And it protects against a large portion of the types of human papillomavirus. Human papillomavirus is usually asymptomatic, like you wouldn't be able to tell if you had it or your partner had it. Sometimes when it becomes symptomatic, it causes genital warts, but most people will notice those, right? But it's usually asymptomatic in men and most of the time asymptomatic in women. So if you can protect yourself against that, then you can decrease your likelihood of cervical cancer. Interestingly, I find this relatively fascinating. I talked to my PA, my OBGYN PA, physician's assistant, about this, and apparently the HPV vaccine is relatively controversial in Utah, which surprised the living crap out of me. So apparently, now it's available for boys. It didn't used to be, but you can get your boys vaccinated early because even though they can't get cervical cancer, they could give their partner HPV, right? And just so you know, even if you like get married and there's two people who say they're virgins, I don't know if you know this, but people lie about sex. I don't know if you've ever known that. People lie about sex, their weight, money. They lie about sex. So let's say you got a little girl who gets married in her virginal state and marries her potentially virginal husband. Let's pretend that happens. It does, I suppose, but not as often as people tell you it happens. And then she gets exposed to HPV because he had sex with even one other person before and then gets cervical cancer. Go ahead.
I had one of the doctors, my doctor's office telling me that things like that you can get exposed even by touching. Like if a guy were to touch you and then touch his mouth or something like that and kiss, like it can be exposed like that.
Yeah. So.
You don't even have to have sex. If he's touching some girl and then goes and touches you or somehow gets it on himself, it gets something like that.
I'm really hoping he would wash his hands between. That's disturbing. I'm like, oh God. I'm just gonna wear like a hazmat suit to interact with other humans. Okay, so but I was talking to her and she said that she's like had these debates / arguments with women who will not vaccinate their children because they think it's like somehow giving them license to be sexually active before marriage. And so like eventually she ended up saying, okay, so you may not be saying this, but what I hear you saying is you would rather her die than be sexually active before marriage, right? Right? You know? Because, I mean, that's kind of what you're saying. I'm not going to vaccinate her against a potential cancer because I think she might be sexually active. Just so you know, people are going to be sexually active because they're going to be sexually active, right? And it's not like, oh, I thought about not having sex, but since I have the HPV vaccine, let's go ahead. Does that ever happen in anybody's head? No, it doesn't, right? But I mean, so she has these arguments with people. But Utah's a strange place to talk about sex. It's a really odd place to talk about sex. And I know my husband comes from a very, very old school, came here with Brigham Young family. So we have all of those kinds of, like, my son is like pioneer stock from Lauren Farr, who had 18 wives. So yeah, I like the whole thing is relatively interesting to me, but I'm gonna shoot up my kid as soon as he turns 8. If I could give him a birth control injection that would keep him infertile till he was 25, I would do that too. Right? I just let's just be safe, right? Until we get 25, we're not gonna knock anybody up. It's not gonna happen. But nobody asks me for some reason in Utah. For some reason. I don't know why. Okay. Anyway, so that's the HPV vaccine. Go get it. Do what the hell you want, but I would go get it if I were you. Let's see, uterus. Supports of the uterus. Supports of the uterus. The ligaments are not hard either. Again, if you just try to follow where they come from and where they go to. The transverse or lateral cervical, also called cardinal ligaments, go from the isthmus to the pelvic wall. They're also supporting the vagina. And then the round ligaments go from the fundus toward the pelvic wall, and they run through the inguinal canal. So they run down and they insert onto the labia majora. So let's find these. So the transverse cervical or cardinal ligaments, where are you? Those are these right here. Okay, so they're supporting this region right here. That good? Okay, and then these guys right here. This guy right here goes down. Hold on, where did I lose it? Transverse cervical. The broad ligament is also supporting. I didn't write it in there because we learned it before. Ureter. Is this one not labeled? Huh? No, the round ligament's there. The round ligament. Yeah. Oh, sorry. I was doing the wrong one. The round ligament. You can't see where it goes, but it actually goes through the inguinal canal, which is the same tube that the vas deferens go through in males, and it inserts out onto the labia majora. And then, of course, they don't put them on here, but the pubococcygeal muscles down here would support the uterus as well. The urogenital diaphragm muscles. That good? Okay. The tissue layers of the uterus. Let's do it this way first. Where'd you go, uterus? Okay. The tissue layers. The inner layer of the uterus is called the endometrium. I'll talk about that in more detail in just a second. The myometrium is the muscular layer. Of course, it's smooth muscle. And then the outer layer is called the perimetrium, and it's serous membrane. So the endometrium is the one that's kind of unique because the endometrium actually has 2 different layers in it. And what happens is you actually expel through menstruation 1 layer every 28 days when you're fertile. So here's the deal. Here's the myometrium. So that's the smooth muscle, right? Okay. And then this whole thing is called the endometrium. And the endometrium has this basal layer that you keep all the time. And then what happens under the influence of progesterone, every month the basal layer makes a new functional layer. So it develops a new functional layer every month, which is really, really vascular, and it's actually tissue. And so it thickens as your progesterone level rises. And then as soon as your progesterone level drops, you actually menstruate all of that tissue and the vascular fluid that is in it. Does that make sense? And then it happens again every month. So you get a new functional layer every month, and the basal layer stays there. Cool? Okay. Blood supply to the uterus, and then we'll talk about endometriosis. Blood supply to the uterus, not surprisingly. Internal iliac arteries, right? That's where it should come from. Go to the uterine arteries. You don't have to know all of this in much detail. As a matter of fact, they don't show this in your textbook, so uterine arteries is fine. But I will tell you that not only do you menstruate some tissue every month, but you actually lose these spiral arteries that are actually in the inner layer every month. So you actually lose arterial flow, not just capillaries. And then you make new arteries every month, and then you lose them, and then you make them, every month, which is kind of interesting. So let's talk about endometriosis just briefly. Endometriosis is a strange disorder. It's very, very sensitive to hormones, and it is as close as you can get to becoming a cancer without being a cancer. So what happens is that inner layer of the endometrium, the whole endometrium should stay in the uterus, right? But for some reason, for reasons we do not understand, in some women, the endometrium will migrate out. So it stays in there, but in addition, it will, for instance, go up into the fallopian tubes, okay? And then since the fallopian tubes are open, it can go out of the fallopian tubes and start growing on organs in the abdominopelvic region. It can go all the way up to the diaphragm. But here's the issue with that. When the progesterone level drops every month, what's going to happen is the woman is going to try to menstruate that inner functional layer, and it is so incredibly painful when it occurs anywhere but the uterus. So the uterus is supposed to slough that off every month. But now what happens when your progesterone level drops and you're trying to slough it off from inside your fallopian tubes, the tubes get irritated, it scars the tubes. When you're trying to slough it off from in here, in addition to it not having anywhere to go, it hurts like hell. Okay, so we don't know why endometriosis happens, but it is a big cause of infertility because it will scar the hell out of your fallopian tubes. One of the few things we do know about endometriosis is that it's really sensitive to hormones. So because it causes infertility so early, a lot of times when a woman is diagnosed with endometriosis, even if in her teens, I had a friend when I was in college who was diagnosed in her teens, and her doctor told her at age 18, if you would like to have a baby, you probably should do it now, because the scarring happens. And then in addition, sometimes the pregnancy hormones will make it stop for reasons we don't understand, right? So you just like get your hormones all screwed up and then the endometriosis goes away. Sometimes women have such problems with it that they end up having radical hysterectomies because of the endometriosis, just like have everything taken out. Because it can make a woman, for instance, be in pain for 3 weeks of the month, 4 weeks of the month. Because when you try to slough it off, it doesn't just go out of the uterus and it's over, right? It's constant, like trying to slough it off from places that you aren't supposed to have it. So it's kind of like a cancer with the exception of the fact that it respects the boundaries of the peritoneal cavity. So it can grow all on these organs all the way up to your diaphragm, but it never goes anywhere else. As far as I don't know if I can say never, but I don't know of any instance in which it goes anywhere else. Does that make sense? Okay.
My sister-in-law had that. She already had 2 kids when she was diagnosed with it.
Mm-hmm.
They said they went and they like burned it off.
Yeah, sometimes that works.
Don't have kids.
Yeah. Sometimes it works if you burn it off. And sometimes you can burn it off multiple times. They just go and do an ablation, take it off, and then it's a while before it comes back. They never really know. Like I said, we don't actually understand why this disease occurs. So the treatments for it sometimes work really well and sometimes they don't. And sometimes they'll do something as early as just putting them on birth control and it'll help control your hormone level. But sometimes it doesn't work at all. I know some women who have had this. They're like just almost put out of commission for most of their life because of endometriosis. And eventually they're just like, just take it. I don't want to deal with this anymore, Okay, so we will pick up there on Monday.